Okay, so our next speaker, we have Dr. Christiaan Stevens, is a radiation oncologist and the medical director and head radiation treatment program at the Simcoe Muskoka Regional Cancer Program at the Royal Victoria Regional Health Centre in Barrie, Ontario. He joined the Department of Oncology at RVH in 2010. His clinical focus is breast, genitourinary, and lung malignancies, and his academic interests revolve around quality and safety in radiotherapy. So please welcome him to the stage.
Okay, so thank you very much, and we're now good afternoon to everybody. Miigwech and bonjour. So as Mike said, my name is Christiaan Stevens. I'm a radiation oncologist at the Simcoe Muskoka Regional Cancer Program. And it's really my privilege, and thank you very much for inviting me here today, to speak to you really about what I think are some sea changes in the way we're treating certain subtypes of cancers. And specifically, I'm going to talk to you about what we call oligometastatic cancer and the role of what we call stereotactic radiotherapy in the management thereof. So there's a couple of terms there that probably require some definition. Just some disclosures. I have received honoraria from AbbVie and Boehringer Ingelheim, but no other disclosures to talk about. So just a brief overview of what I'd like to cover in the next 20 minutes. I'm going to talk about oligometastatic disease and what I call phylogenetic trees of cancer. Then we're going to talk about the rationale for locally ablative therapies, which include surgery, sort of radiofrequency ablation or interventional radiologic techniques, and then radiation itself. And when we talk about radiation for locally ablative therapies, I'm going to refer to stereotactic body radiation, or it's an analogous term, something called Sabre, or stereotactic ablative radiotherapy. And then the evidence to support it. So where are we going? Where are we now in 2019? So the concept of metastases, oligometastases, really bears some further delineation. So when a primary cancer arises, tumor cells and clonogens can then be elicited through the hematogenous spread or lymphatic spread through the body. So there's really a spectrum of disease where you have local disease where the cancer remains where it started, and all the way to the end of that spectrum where the disease is very widespread and distributed. And several years ago in 1995, Hellman and Weichselbaum proposed in the Journal of Clinical Oncology this concept of oligometastatic disease. And the word oligometastatic disease refers to the prefix oligo, which means Greek for a few, and metastases meaning spread. So it means a few metastases, a few diseases spread. Now, what is defined as oligometastases in the literature is quite variable, but typically, and it's somewhat ambiguous, but typically it's 5 or less metastases. Now, obviously that's based on conventional imaging that we have to try to find metastases, such as CT scans, MRI, ultrasound, whole body bone scan. But they're very insensitive, in fact, for finding metastases. So there's a lot of novel imaging techniques that are trying to find metastases much earlier on in the course of disease. I'm not going to talk a lot about that, but that's a huge area of interest in research right now. So they proposed in JCO in 1995 that there's this state, this intermediate state between cancer that's localized only with no evidence of spread, and then this widespread disease. And they provocatively said that in these patients, where there may be only a few areas of metastases, if we potentially treat these areas aggressively, could we cure metastatic cancer? Okay, and it's very provocative, but it's become now a very topical issue, and a lot of work is being done on this patient population. So why? So this is what we call a phylogenetic tree in cancer. So what happens is you have a primary tumor that arises in some part of the body. It could be the prostate. It could be the breast. It could be the lung. And this cancer, as you learned from Dr. Mack, evolves for many different reasons. But at some point in time, that tumor or the evolution of that tumor, something happens that enables those cells to potentially leave that primary site and go somewhere else. So in this diagram, you have on the left-hand side this patient in whom has developed metastases that have been labeled 1, 2, 3, and 4 in the liver, in the bone, in the lung, and in the brain. And this arises from a primary site. It doesn't really matter where that primary site is. But at some point in time, the evolution of that tumor is such that you have different cell populations that have been distributed elsewhere in the body. And this is kind of depicted by this line and then this split. So this M1 cell and M2 cells are actually now separately evolving cancers. They may be influenced by similar things, but they're evolving somewhat independently of one another. And this metastases can then beget different metastases that are evolving separately from that. So it's like an evolutionary tree of cancer happening in this patient's one single patient. Okay. So one metastasis can evolve very quickly to seed other metastases. Okay. But this doesn't necessarily immediately happen at the development of the primary tumor. So this could be a process in evolution. You'll hear me a lot saying about evolution. So the question is, if very early on in this evolutionary process, we very aggressively ablate these areas of oligometastases, including the primary, can we potentially prevent these downstream processes from happening that results in the disease being widespread? Okay. And that's sort of the whole premise underlying this concept of locally ablative therapy, and that can be in many different forms. As I mentioned, it can be surgery, stereotactic radiotherapy, or interventional radiology techniques. Now, I'm going to focus mostly on radiotherapy, but these other two approaches have an equal and important part in the management of this type of disease. Now, it seems like a very simple model. In reality, it's much more complex than that. There have been some really elegant studies following patients from very early on in their diagnosis through their imaging to, unfortunately, their death, and then doing autopsy studies showing the myriad ways in which cancer arises in a primary tumor and can then seed different parts of the body. It's actually kind of breathtakingly complex, but models obviously very rarely reflect how the complexity of the real state in the biological system that we exist in. So just taking a breather and going to radiotherapy. So when I refer to stereotactic radiotherapy, what I'm referring to is a highly focused modality of treatment that is able to deliver a very high dose of radiation to a very small area. Okay. And the benefit of potentially doing that is that we can increase the amount of radiation we give to that small area. And as you increase radiation to the area, in general, studies over many decades have demonstrated improvement in control of the disease in that area. Okay. Now, in the past, we haven't really been able to do that, although this is actually a really old technology. In the 1950s, there's a researcher called Lexell in Sweden who developed a technique of doing this. But at the time, there was a lot of things that we didn't have: computing power, other forms of what we call immobilizing the patient's body, because when you breathe, lungs move, the tumor moves in the lung. How do you deliver a very highly focused dose of radiation when your target is moving, right? Or the prostate, for example, the bowel, gas moving through the bowel, the bladder filling, prostate moves around. So things in our body are moving continuously. The question is, how do we try to account for that? And it's only in the last 10 to 15 years that we developed technologies that are enabling us to do that. Also, imaging. Imaging has improved dramatically. In the past, we used to do an X-ray. A radiation oncologist used to draw with a wax pencil the area of concern. There would be very fundamental fields, and then we used to deliver it. We actually didn't see what was happening during the treatment of that tumor. And what has happened now, due to a lot of work from a physicist at Princess Margaret, has developed that CT imaging is actually integrated into the machine that delivers radiation called a linear accelerator. And before treatment, and even in some cases during treatment, we can actually image the patient as we're delivering radiation. And in so doing, we're able to see what the tumor is doing and account for its movement. And then clinical imaging has improved dramatically as well with improvement CT and MR technology, but also positron emission tomography, or PET scanning, and the various different types of modalities of PET that are having an enormous impact on this. So just on the left-hand side, let's say someone's developed a metastases in the lumbar vertebra. Let's say this is the fourth lumbar vertebra. In the past, we used to deliver a beam potentially from in front and from behind to try to treat that. Now, this color that you're seeing here is the distribution of the dose of radiation. Our target is this, but look where the dose went. Anteriorly and posteriorly. Okay? So you were able to deliver the dose to where you wanted to, but you also delivered a dose of radiation to a lot of other structures that you didn't want radiation to go to. And because of that, we couldn't deliver very high doses to here because of concerns about dose to the bowel and other structures, and the spinal cord itself, which runs behind it. This is an example of treating the same vertebral body with SBRT. Okay? And consequently, you can deliver a very high dose of radiation to the bone itself with relatively low dose elsewhere. You can imagine an actor on the stage, and you have only one or two spotlights. In order to illuminate that actor with the two beams, the beams have to be at pretty high intensity. But if you have 9, 10, 12 beams focused on that actor, each beam itself doesn't have to be as high intensity. But where they're all intersecting at the actor on the stage is very intense. So you get this low dose kind of spread everywhere, but the high dose focused on the bone. So that's what we're talking about when we talk about stereotactic body radiotherapy, or Sabre. And it's enabling us to deliver really, really high doses of radiation to small areas. And now the way the radiation is working in the tissue is actually different than when you deliver it low dose. It's actually ablative in terms of its local control of the tumor. So how do we use this? We have this wonderful technology. We're very good in science and in medicine, and I think Dr. Mack referred to it as having all these wonderful tools, but how do you use them responsibly? And do you know when you're using them that they're actually effective? Because human beings are kind of nicely affected by the nice, bright, shiny new tool and new technology. But is that technology actually useful? And is it doing what we believe it to be doing? So this is just a further example of, we have a fourth linear accelerator, which is called a true beam. And this is a patient who's receiving radiotherapy. And you can see the amount of immobilization that we need to employ to ensure the patient movement is minimized. So this is it's a kind of a vac lock, which is kind of like an anti-beanbag. Patient lies in it, and that air is sucked out of that bag, and it conforms to the patient. And then we have this, which compresses the abdomen so that it minimizes the breathing for the patient to minimize lung excursion. So there's a lot that goes into trying to be as precise as we can. And these are examples from my patients of SBRT. This is a woman who has a metastatic breast cancer. It's recurred in her brain. And this is sort of the type of dose distribution we can get around these tumors without radiating anywhere else in the brain. This is an adrenal metastasis. This is the high dose area. You can see that there's kidney right here. There's actually loops of bowel. And this is the 95%, so that's the sort of the highest dose of, well, not highest dose, but the high dose of radiation. And this is slightly lower dose, and you can see very quickly that this isodose line, this blue, is 50% of the dose we're delivering, how it drops off very quickly from our target. And this is, again, another example in the lung, of lung SBRT. And this is a femur bone met that we're treating. So, great tool, great technology. However, are we using it appropriately? So oligometastases and the treatment thereof have been described anecdotally for over 80, 90 years. So this is from the journal Urology, 1939. So a young woman presenting with metastatic kidney cancer. She had a kidney removed, and she had radiation to the metastases in her lung. She had a single lung metastases. The dose of radiation used would almost be homeopathic compared to what we would use today. And then she subsequently went on to have that lung resected. And she was alive 23 years later. The literature is kind of peppered with these anecdotes of patients that you believed who had metastatic disease, which by all accounts is generally incurable, who've lived a long time. So the question is, who are these patients? What makes them different from those who have more widespread disseminated disease? Okay. And from hundreds of observational studies, you get graphs like this. So this is really just a composite of all those observational studies that patients presenting with oligometastatic disease based on the conventional imaging we had at that time and at this time, say with 5 or less metastases. On the x-axis, you have time in months. On the y-axis, you have survival. There is typically this curve, this tails of the curve, where 25 to 30% of patients are alive at a very long time afterwards. So that means even though patients were diagnosed with oligometastatic disease in the beginning, only about a third of patients over time actually have long survival. So the question is, how do we better select those patients? Or how do we find these earlier? Those are the questions. Okay. And with respect to SBRT, there's been now hundreds of single institution prospective studies of data of SBRT in treating these metastases that have shown excellent local control, about 80 to 90% local control of where we treat, and also what we call improvement in progression-free survival. So how long people live without evidence of progression of their disease. But the question is, we don't really have a lot of overall survival data, which is in some respects the holy grail of most clinical studies, although quality of life cannot be diminished. And because of those studies, this is a study of over 1,000 radiation oncologists internationally. About 2/3 are using SBRT for oligometastatic disease. This is in the absence of overall survival data. So it's been this rapid uptake of utilization. The question is it responsible? Okay. And at the same time, the rise of SBRT has been a rise in metastatectomy, so surgical management of metastatic disease. You can see this on the x-axis, there's years, and these number of procedures on the y-axis. You can see how for colorectal cancer, which is really the kind of the poster child for metastatectomy in cancer, but lung cancer, breast, and melanoma, how you've seen this rapid increase over the last decade. So the question a lot of people will say, a lot of cynics will say, well, yes, it's all good, but it's all selection bias. You're selecting the best patients. They've had chemotherapy, they're doing really well, they've had their disease controlled, so when you treat them, of course they're going to have better progression-free survival because the people who are destined to do well are doing well. And that's why you need randomized controlled trials. That's why they come in kind of this rushing in to save the day. Because when you randomize somebody to one treatment versus another, you eliminate or almost eliminate most bias. Okay, so all those prospective studies and retrospective studies are all fraught with a lot of selection bias, unconscious or conscious. So you need randomized controlled trials to support that a treatment is of value, at least from a clinical endpoint. Okay. And so this year, there have been 2 randomized controlled trials that were published. One by Gomez, this is a Gomez study, and the other by a group out of London called the Sabre study that have demonstrated overall survival benefit to treatment of oligometastatic disease. Gomez did this in non-small cell lung cancer, whereas the Sabre study that I'll review very quickly did it in multitude of lung cancers, multitude of different types of cancers. Okay. So these are patients that had stage 4 non-small cell lung cancer based on imaging that showed 1 to 3 metastases, so 3 or less metastases. Again, conventional staging, CT, MRI, whole body bone scan. They had chemotherapy, as would be the standard of care. If they had stable disease on chemotherapy, they then went to local consolidative therapy, which would be either radiotherapy or surgery, to the primary site in the lung, but also to their metastases in their body. Okay? Or they were randomized to no local consolidative therapy, just maintenance chemotherapy or surveillance. Okay? And if the patients progress on this due to selection by the patient and their physician, they could allow to be crossed over to get local ablative therapy. Okay? And this is what they have demonstrated, published in JCO, the Journal of Clinical Oncology, just a few months ago. Progression-free survival, very significantly different between patients who had that local consolidative therapy and those who didn't. Okay? And survival significantly improved. And you can almost look, it's almost triple the survival. In fact, they have not reached kind of one of their clinical endpoints. So they'll be obviously publishing over the next several years when they follow these patients longer. But there, again, is this fairly significant divergence of the curves for a fairly significant patient population. Okay. When you look at the subgroup analysis, we're looking at the prognostic factors. Pretty much, this is called pretty much all patients, no matter what their subgroups, seem to benefit from local consolidative therapy. Okay. This is the Sabre Comet study in London, Ontario. David Palma is a radiation oncologist. He's been pretty influential in this field. So these are patients who have up to 5 metastatic lesions. Okay, could be anywhere. Could be breast, prostate, lung, any type of cancer. Obviously, because breast, prostate, and lung are the most common types of cancers, they were very well represented in the study. They were randomized to either getting standard of care, which could just be conventional palliative radiotherapy or otherwise, or stereotactic ablative radiotherapy to all the sites of known disease. The key thing about the study is their primary tumor, wherever it may be, had to have been controlled. Whether they had disease at some point in time, had surgery, and then they had metastatic recurrence, but it had to be controlled. That's a very key factor in this study. Okay. And their primary endpoint was overall survival. And Dave and his group just published that a few months ago in The Lancet. So progression-free survival, very much like the Gomez study, showed improvement to those patients who had the stereotactic radiotherapy to oligometastases, and then overall survival, 28 months for a control arm, but 41 months for a Sabre arm. And they still, again, like the Gomez study, have not reached their endpoint. So again, this divergence of curves. So both of these studies, plus others that have preceded it, have really given us a lot of encouragement that there are a subset of patients that we potentially, and again, provocatively use the word cure if they have metastatic disease. And these are just a selection of a few studies that are ongoing in terms of accrual in multiple sites. And so hopefully we'll have a lot more data in the coming years to help guide us as to what we should be doing. But in the intervening time, until evidence matures, we are using what we call the 4 ACEs, which are various types of criteria to kind of select which patients may be the best candidates for this type of approach. And that's usually younger patients with good performance status, as many studies do, who have what we call a metachronous presentation. So they've had a primary disease that's been treated, and then only several years later has it recurred. So it tends to speak to something that may have a slightly different disease process than someone who presents who has very floridly disseminated disease at presentation. They probably have a different type of disease process happening. And then presence of fewer metastatic sites, 5 or less, but people are now pushing it to 10, 15, so we'll see where it goes. Okay. So hopefully, I've been able to talk a little bit about oligometastatic disease, and you're kind of familiar with it. You'll hear a lot more about it in your practices and in the community and in the news. Understand a little bit about what stereotactic radiotherapy is and how we use it, and that there is some growing evidence to support its benefit. So thank you very much. I appreciate your attention.
Great, thank you. Thank you so much, Christian. I'll just look to see if there's any questions from the audience. Great, okay, thank you so much.